Okay, thanks very much. And so if I can begin today's proceedings, a warm welcome to you all. Thank you all for braving the cold Edinburgh nights to be here in this latest in the series of our Changing World lectures. I'm Gareth Lang, so I'm head of the School of Biomedical Sciences here, and I've followed the course of this series of our Changing World since its inception, and I'm really enthused by the kind of quality and growing excitement about this series. Well, I'm in the College of Medicine, and so is the speaker tonight. The speaker tonight is Dr. Liz Grant, and she is Deputy Director of the Global Health Academy here. Now, medicine isn't only about curing diseases, it's actually about, also, maybe more importantly, about enhancing the quality of life throughout the lifespan. Now, Dr. Liz Grant is responsible for a wide range of global health programs across the university's colleges. She's responsible for developing and directing new educational initiatives, including the MSc in Global Health Challenges and the MSc in Global Health, Non-Communicable Diseases. She leads the international and the spiritual care strands of the university's primary palliative care research group. As you'll hear, I think, she's a passionate proponent of equitable access to palliative care, especially for those in low and middle income countries. And she is an active advocate of the proposal that palliative care should be on the global health agenda. Currently, she's leading a large grant to help integrate palliative care into the health systems of 4 African countries. Dr. Grant has worked in Kenya previously. She worked there for 5 years as a community health advisor. She's a trustee for the International Disability and Rehabilitation Charity CBM and of Medicine. Previously, she's worked for the Scottish Government as a health advisor in their international development team, as well as for NHS Lothian Public Health Directorate. This year, Liz, with 3 other members of the palliative care team, was awarded the Principal's Medal for service to the community. This is a great pleasure to welcome you tonight.
Thanks very much. Tonight, I'm going to talk about palliative care as a global development challenge. And I hope through the course of this are to describe what palliative care is, to take you on a journey and for you to see some of the places and some of the care that is given and some of the needs that are out there, and how we in Edinburgh and we as part of humanity that's shared across the globe have a responsibility and a right to offer care to others. But I'll start by some fairy tales. They all lived happily ever after. We live in a very death-denying culture, no matter what we think. And it starts from very early on. And even though fairy tales do have quite interesting themes around death and dying, the message that comes out is we lived happily ever after. Death is something that's defeated. We're together. And that does come right through society's view, and particularly through medicine's view. Death is something we'll stave off. Medicine is for cure. And there's a problem with that attitude. In fact, the other day I was coming through one of the airports and I picked up the Time magazine because of its front cover. Google has decided, can Google solve death? We're at that stage, 21st century, can Google solve death? Can Google make responses? Richard Smith, who's one of our colleagues and alumni, he used to be editor of the BMJ, quoted Ian Morrison, who was the president of the Institute of the Futures, who's a Scottish man. And Ian has this wonderful comment that Richard often tells, and I want to tell it. And he says, in Glasgow, where I was born, death seemed imminent. In Canada, where I trained, it was thought inevitable. In California, where I now live, it's considered optional. Death. The problem is, we all die. Diseases are curable. We can push death forward. It's our duty to prevent preventable deaths, and a lot of global health is trying to prevent preventable and ensure that people don't die early. But death's not curable. And I want us to think about that tonight, because it means that every single person in the world, every single person in this room, at some point or other, we will die. What will that mean? How do we manage? I'm going to change tack, and I'm going to ask you to think about dying, because we all will die, but some of us will die in a better way than other people. But ask this question: how does it feel? Are you ready to die? Not now, not hopefully tonight. No one wants to die. No one believes they're going to die tonight, tomorrow, the next week. Many people in the world tonight do know they are dying in the next few hours, the next few days. But are we ready to die? It's not a question that we're often asked. It's not a question that has an easy answer, because it lies behind us. How do you prepare to die? What does that mean? As I go through this lecture tonight, keep that question in your mind as we think about how we can support other people to prepare to die, how we, in the end, can be ready to die. So just to give a quick definition of what palliative care is, end-of-life care. So many of you in the audience are more expert than I in end-of-life care, palliative care. But just I want to describe what we're talking about. I'm using a quotation from Dame Cecily Saunders, who really was the founder of the modern hospice movement in the UK, an extraordinary woman. A woman who who was a social worker, who saw what was happening, who went back into the hospital, trained as a doctor, saying, we've got to do something for those many people who are being left, who are being pushed to the sides. And I love this comment from her. And it says, you matter because you're you, and you matter to the end of your life. And we will do all we can, not only to help you die peacefully, but also to live until you die. Palliative care is also about helping people live until they die. The WHO has a definition. Palliative care is an approach that improves the quality of life of patients and their families facing the problems associated with life-threatening illness. And these are the criteria: through the prevention and relief of suffering by means of early detection and impeccable assessment and treatment of pain and other problems, physical pain and physical problems, psychosocial and also spiritual. Palliative care is about a system of care, but it's more than that. It's about an approach to care that all clinicians, all health workers need to be able to recognise that palliative care is part of a continuum of care, and it's a service. There's a lot of work in the University of Edinburgh here. The primary palliative care unit in the College of Medicine has done some extraordinary work looking and reshaping policy, both here in Scotland, but policy in the UK and policy globally around new understandings of what palliative care is. And Professor Scott Murray, who heads that unit, has really innovative around how people think about care. You can see from this slide, the old concept of palliative care was we moved along things to curative, and then suddenly, well, there's nothing else we can do. This person, they're palliative. Let's move on. But there's a new concept, a better concept that holds palliative and curative care together for some time. A concept that moves along realising that gradually things will change, that gradually come to a stage where a person's illness is no longer curable. But not being curable doesn't mean that it's no longer treatable. Not being curable doesn't mean there's nothing else that can be done. There's a huge amount. And also, palliative care doesn't finish when the person dies. We all leave behind someone else. We leave behind families, we leave behind others. There's something about holistic palliative care that means we need to care. Now, I'm asking you to think of that here in Edinburgh, in our context. But as we think globally, we really begin to see where the gaps are in a service. As the title of this talk really tries to say, there's something wrong. Palliative care is missing from the global health agenda. It's not there in the MDGs. Mind you, there's a lot of things not there in the MDGs, but it's not there. Why is that important? Well, one of the reasons it's not there is because the MDGs and the successors, the Sustainable Development Goals post-2015, as we think, are really fundamentally about how do we get poverty alleviated? How do we improve the health of the world, the social well-being of the world, the development of the world? And palliative care is not seen as one of our poverty alleviation measures. It's not seen as contributing to an economically viable society by those who are setting agendas. And many of you know that in a number of low-income countries, there's the health service has been constructed around an essential health package for countries that can't afford to internally fund their health service. And a lot of funding from aid organisations, such like our own Department for International Development and the US department, the Scandinavian departments, a number of the European departments have put in funding to essential health packages. And these essential health packages are very much efficiency-orientated packages. They're about what's the best win for the least money, to be strictly honest. How can we get most people served in the most effective, efficient way? And palliative care is not seen as one of those essential health package components because it's not seen as valuable. And yet there's huge repercussions because it's not seen as valuable. There's huge repercussions to people's families' economies, to people's well-being, and I'd argue to actually how a nation functions. This slide just gives you some indication of the palliative care worldwide, where we can see sites of palliative care. And as you see in the countries that are covered red, those countries have almost nothing. And you can see coming down, there's some capacity building, but tiny amounts, very, very limited, right really up until the darker green where we get advanced integration. The message is there's very limited palliative care throughout the world. I apologise for my slightly hoarse throat at the minute. So why does this really matter? Well, it matters because there's a global health reason I want to talk about the way diseases are changing. There's an economic reason why it matters. And for me, really, there's a very strong ethical, moral, justice reason why we need to do something about this. 100 million people are estimated to need palliative care in the world as we speak, and 8 million receive it. It's not news to you that the disease profile of the whole globe is changing. The 21st century is seeing a completely unusual presentation. And one of the ironies, I think, of 21st century health, like no other century, is that the drivers of health, the drivers of economies are also the drivers of illness. The drivers of economies will destroy health. What's really driving a lot of our economies? We think about the big global pictures of the industry that's really in there, the industries that and the global corporate institutions that are really functioning. You think of the big ones like Coca-Cola, Nestle's, whoever. You think of the push of tobacco. You think of the push of the sweetened drinks, the push of junk food, the push that's there. Those drivers that are making huge fun economies rich are also destructors of health. They're destroying nations. So we've got this unusual thing happening in the 21st century, and it's exhibited very much in the rise of non-communicable diseases. Those are the diseases like cancers and COPD, diabetes, diseases that initially everyone always assumed these are the diseases of the West and then the diseases of tropical countries or low-income countries are not non-communicable diseases, because these diseases of non-communicable diseases are very much associated with the luxury life, with the choice life, with the life that has the Coca-Cola, the tobacco, the whatever. But things have changed, and the non-communicable disease burden across the globe is huge. The Lancet study that was just come out last December, the Global Burden of Disease study, was really showing how the non-communicable diseases have really crept up. And we know figures coming out of China, figures coming out of India are shocking, with the number of people who have diabetes, the number of people who have COPD, the number of people who have cancers. And this has a huge impact. Now, a Greek myth for those of you who know your Greek mythology. Eos and Tithonus. Eos, the goddess of the dawn. And she fell in love with Tithonus, a mortal man. And she wanted to be with him forever. So she begged Zeus. She begged Zeus for immortal life, for eternal life for Tithonus. But she didn't ask for eternal youth, eternal life. And Tithonus and Eos lived and lived. And then Tithonus began to get older and older and older and more fragile. And it's one of these extraordinary descriptions of disability, an extraordinary description of effectively Alzheimer's, an extraordinary description of an old person losing all their faculties. In the end, she begged Zeus to change things. And all he did was he could change Tithonus into the grasshopper, so that his chirping, his endless chirping, wouldn't be annoying everyone. This early myth capturing chronic disease as we never thought we'd see it, capturing a particular type of illness that's moving on. These next two slides are from a colleague of mine, Professor Bruce Guthrie in the University of Dundee. And what he tries to show is the extraordinarily multimorbidity that now impacts the whole of, the whole of European society. These figures are from the UK, and it's a very nice presentation published in the Lancet last year, just really capturing, as you see, as people get older, the number of conditions that they become ill with. And again, looking also at polypharmacy. As people move along, the number of drugs are on, from one drug right up to 15 or more drugs, as illnesses come, not in single illnesses, but come. See, we've got this problem. Sorry, this slide hasn't come out terribly well, but the world has speeded up, but actually dying takes much longer now, because it's the one fundamental thing about chronic diseases, non-communicable diseases. Unlike some of the infectious diseases that we did see in various places within that tropical band, diseases where if someone got better, they got better, but if they didn't get better, they died. Chronic diseases are diseases we live with, and diseases we live longer with, and diseases in the end we die with. And this is part of my argument of why we really need palliative care, because it's not just here in the UK, it's not just in the West that we have non-communicable diseases affecting our whole population. It's everywhere, and it's particularly in low and middle income countries, where we're seeing this extraordinary disease, what I'm calling a disease vortex. We're just seeing non-communicable diseases coming in on top of infectious diseases, because infectious diseases haven't been cured. There's a huge number of infectious diseases affecting the globe, a huge number also of neglected tropical diseases that we're not doing so much about. Though I want to say here that Edinburgh, the University of Edinburgh has such a strong department, a whole grouping of people looking at neglected tropical diseases. But you're seeing in sub-Saharan Africa diseases merging together, coming together in a vortex, people living with lots. And as we know, HIV, it ravaged Africa. It was awful. But we got, the antiretrovirals have been fantastic. They've changed the face of HIV. They haven't, and people are not dying as quickly, but people are living much longer with HIV, but they're also picking up now different non-communicable diseases. So we're seeing this very odd interconnection, people who are HIV positive, who have diabetes, HIV positive, who have cardiovascular disease, and they're aging in a very different way than we expected, living with a chronic infectious disease. Sub-Saharan Africa, 11% of the world's population, 24% of the global disease burden, and less than 1% of global health expenditure. So it's quite hard sometimes to argue that, given that condition, how do you argue for something that seems, as someone once said to me about palliative care, a very niche area to be in, Liz, a very niche area. I think, well, to be honest, the 7 billion in the world will probably die, and actually probably 80% of them will need some sort of palliative care. So it's not so niche, but I can see where the person was coming from. That's why I want you tonight to persuade you the value of this. This is a slide on cervical cancer, and I think not many of you may realise again how horrendous the cancer burden is in a number of low-income countries. Look at Eastern Africa leading the way. Zambia is a country that seems to probably have the highest number of women with cervical cancer. And the problem is the majority of them are not getting into the service early. So the majority don't come in for early stage treatment, and cervical cancer is very treatable, caught early on. The majority of these women are coming in towards the end. The majority are coming in with the most awful pain. The majority are coming into health services to die. A second reason why I think palliative care is so important, alongside this changing disease burden that's going to see many more people living with needing support, is I really do believe it is the quality signature of a nation. It's the way a nation manages birth and death. At those 2 points are the points when people are most vulnerable. Those 2 points are the points when action needs to be taken. When the little baby, when the person who's dying have probably very little economic value, but a huge value as a person, as a sister or brother within that nation. Palliative care, I'd argue, is a human right, and there's a document that's just come through, which the European Association of Palliative Care, which we've been very involved in, has led the way in producing the Prague Charter, arguing that palliative care is a human right under the right to highest attainable standard of physical and mental health. Back in 2005, WHO argued that it was an urgent humanitarian responsibility, a basic human right. The number of people who were dying without any support, who were dying in pain. Professor Harvey Chuchanoff has made this one comment, which is quite insightful, and I'll read it. Unfortunately, in end-of-life care, we don't have a vocal constituency. The dead are no longer with us. They're no longer here to speak. The dying often cannot speak, and the bereaved are often too overcome by their loss to speak. So others must speak for them. And Human Rights Watch, and we're going to watch a short video of that in a few minutes' time. Human Rights Watch has throughout the globe pulled together a huge number of resources, but they have a report. And one of the strong messages that came out at the start of that report was the comment, "Don't make us suffer. Please do not make us suffer anymore." As a human right, what can we do? Human right, because we can, as a right to support the family and individual, a care that causes no unnecessary suffering, doesn't hasten nor does it postpone death, allows people to live and die in dignity, is not to be feared or ignored as service. So I want to now just talk through what's happening in some countries. Now, a lot of my work has been in sub-Saharan Africa. So while I'm trying to give you this global picture, I'm going to give you some snapshots from the countries that I've worked most closely with in building palliative care, so that you can begin to see where, how palliative care has changed. But I want to just ask you to think about this. In maternal health, which is in the global health agenda, one of the reasons that it was so powerfully on the global health agenda is because a very simple message came out in the 1990s, and in fact just before, saying there's 3 delays that really influence why women die in giving birth. There's 3 delays, and if we can do something about those delays, those three things, we can make a change. And those delays were a delay in decision to seek care, women not being able to come forward because they were waiting for their husbands or the chief or somebody to give permission to come to the care, a delay in getting and reaching the obstetric facility because there was no transport, there was no one to bring the woman, they had no money, there wasn't, the place was too far away. And then when women arrived at clinics or at the hospital, there was a delay in actually getting the right person to deliver. I think there's 3 delays in palliative care as well that are really important, and if we could address those, we can make changes. Things could happen. First of all, a delay in knowing what is happening. And why? Because often, like we ourselves at the start, we often are in a society where it's hard to give the message about death and dying. It's hard to talk about dying. Very few clinicians in many African countries, in many Middle East countries, in many Asian countries, and here sometimes in our own country, though we have palliative care within our medical curriculum, within our nursing curriculum, within our pharmacy curriculum, very few clinicians, few health staff feel comfortable about speaking about what's going to happen. Breaking bad news. So many folks have talked to me about the difficulty. It's better just not to tell the person what's happening because lots of reasons they'll lose hope. But it's actually quite hard. And in my work in Kenya, one of the hardest issues was actually listening to doctors and nurses saying, but if I tell this patient that they are going to die, I'm almost giving them a curse because I'm telling them that their life has ended. I'm telling them I cannot do any more. I can't heal them. And they've come to the hospital for healing, and I'm passing the message of death on. So some of this is definitely around education, it's around support, but realising and recognising that within societies there's cultures, there's religious beliefs, there's social beliefs that really mould and affect. But what happens when you don't know? As a number of folks used to, and in some of the research work around looking at what was happening, people would say we were always searching for cures and never finding them. Patients go from one place to another, to charismatic sects, to healers, who take the money and give them useless things, but there's nothing. But no one has told the family, there's nothing we can do. And that's hugely costly. Hugely costly. And I put up 2 quotations from work we did, both in Uganda and Kenya. They really capture the problem of not telling what's happening. In Uganda, an aunt of a patient who described how she spent a huge amount of money on care that failed to heal him because he had cancer. The illness he had was never going to be healed. She took her children out of school. She sold her inheritance. I sold land, cows, goats, chickens. And an aunt and a patient in Kenya talking about there's no money any longer in the family because of the many times I kept attending dispensaries or dukas and didn't get well. A huge economic cost, a spiral that puts whole families into poverty. And there's fear. That delay of not knowing what's happening. Patients do know what's happening. Patients here know what's happening. A lot of people know what's happening, but no one wants to confront, no one wants to discuss. And there's certainly a real view, and you can recognise it from what happened some years ago here, where cancer, certainly in the 50s and 60s, was a word that wasn't used, it was hushed up. Now that word cancer is a word that's hushed in many places in Africa. It's there, the burden is huge, but people don't want to mention it, don't want to talk about it. And secondly, there's a delay in receiving the right level of care. And what happens are 2 different things. Sometimes patients come in, and it's not that they are not given any care, they're given a huge amount of care that's not appropriate. It's aggressive care with an aim for cure, because no one wants to talk about what's happened. Or care is at the back of the ward. The doctor who doesn't go by the patients at the back of the ward because they know there's nothing they can do. The nurses know there's nothing they can do. But the patient and their family keep waiting each day thinking, the doctor will come tomorrow, the doctor will come tomorrow, somebody will come tomorrow to tell me what to do next. And I've seen situations, particularly in Uganda, where people have stayed in the wards, stayed until they were too ill to possibly go home because they kept waiting for someone to come and say, this is what we're going to do. This is how we're going to remedy this, what you have. There's a study conducted in Malago Hospital. Malago is one of the main hospitals in Uganda, in Kampala. And we work very closely with Malago, with the Makere Palliative Care Unit as part of the Global Health Academy work with our team in Uganda. And that study looked at patients throughout the wards, the surgical and the medical wards. Now, this is a hospital that has thousands of patients through it. So it's a huge number within the hospital. And they recognised, they found 45% of the admissions had life-limiting illnesses. There was such a high level of indicator symptoms, and yet less than 5% of those people were receiving any sort of care for the end of their life. Most were being told, wait, something's going to happen, buy some more treatment, wait, or go home and come back in 2 months' time and we'll see if things get better. I put this quotation as well from Professor Gwandu from Harvard University, because it also just captures a very different sense of the cost of end-of-life care. The cost in the US, the cost in the UK, the cost is huge. And he comments, our medical system is excellent at trying to stave off death with $8,000 a month in chemo, $3,000 a day intensive care, $5,000 an hour surgery, whatever. But ultimately death comes. This whole sense that there's all this money being thrown, it destroys families, it destroys the economy. We often think of it destroying families in the US. We maybe don't think what it does to families who are so poor already that they're pushed into it. There's also, because of that delay, there's a delay because of the lack of time, of knowledge, of skills among busy practitioners. There's unclear decision making. No one wants to say because that the disease is incurable, because clinicians have said, but it reflects badly. It means that I haven't somehow got enough training. I'm not knowledgeable enough. I'm not skilled enough, because we were never taught this. So therefore, I should be able to make things better. There's also uncertainty. We have a miscommunication that palliative care comes when everything else has failed, and it will be seen to us. Which to me shouldn't be the case, said one Rwandan physician, as he really tried to argue with all his other colleagues that things needed to be better. But some of you may be hearing this and thinking, I can associate with this. I've seen this happening here as well. It also is because of a whole cycle of endemic system failures in healthcare systems that are crumbling. And we have to be honest, a number of healthcare systems across the globe are really struggling. And as I talked about this, diseases are escalating. Chronic diseases are escalating. That's putting more and more demands on health services, which were configured initially for infectious disease management, and configured not to have a long-term continuity of care system in place. But as one of my Malawian colleagues said, these are the things, delays, these are the delays. This is what's happening. We've got to recognize this is the situation we're dealing with. And I want to very specifically focus on something, the absence of pain relief. When I lived in Kenya, I was carrying out research along with the University of Edinburgh here. I was an honorary fellow of here while I was there. And one of the study we were doing was looking at the care needs of patients in the Chigori area, and then also looking at the care needs of patients here. Two different groups of patients with very what seemed like very, very different needs, but it was quite interesting to find how many of them actually collided, how many began to hear similar things coming. But this would not be a comment that you would hear from a patient at Little France. A woman who said to me, I want to go to sleep and wake up dead because the pain is too much. To go to sleep and wake up dead. Why? We can reduce most pain with very little money. It's possible. We know how. We've got the drugs, the system's there. So what's happening? What's happening that people, thousands and thousands of people, are living in huge pain because of their cancers, because of their many illnesses? showing you two slides here. This is a slide of morphine consumption in 1989, and if you have a look, you can see the countries where there's a lot of consumption, the countries where there's little consumption, countries where we don't know what's happening at all, or we didn't know what was happening at all. And this is a slide in 2009, and you can see, I'll just go back, you can see a change, actually a positive change, but Africa's not changing. The Middle East is not really changing. There's a huge problem of getting morphine into many countries. And this slide, I hope, just tries to show the global consumption of morphine. Some countries that are off the scale, really. And then you've got the European countries, many of them which are using a huge amount of morphine. Why is it? Why are these countries off the scale? Lots of reasons. There's lots of beliefs about morphine use, beliefs that have come into the system, beliefs that are actually mythologies, that have maybe a thread of truth that has been moved into a whole sort of value-laden system. But there is beliefs that have no truth, beliefs that tolerance to morphine occurs rapidly, so don't give it to the very end because the patient will become resistant, so it will not matter. The patients, and often I hear this, patients who are taking morphine, they'll become addicted. You wouldn't want to give that because, morphine's very addictive. And these are, when you realise you're working with patients, nurses and doctors are working with patients who are in the last few months, few weeks of life. Addiction actually wouldn't matter, but the pain level will mean these patients won't become addicted. Morphine masks the signs and symptoms of disease, so we don't really know what's going on. There's lots and lots of views and beliefs. And one doctor, particularly in Uganda, was talking about morphine and saying, well, actually, one of the issues is because we get all this messaging coming in from other countries. Some of it not so good, some of it coming in the films, Bollywood's evidence-based medicine, that actually you can't use morphine because patients will become psychologically dependent. Something's happening, and I want to just try and quickly describe what's happening around morphine use because it's really important as we think globally then what we can do. The WHO, in their essential medicines list from 1977 actually, identified morphine as part of that list. So it's in the system, and in fact in 2013, just this year, with a lot of advocacy work, a whole section on pain and palliative care was put into the WHO list. So we know that there's a way of getting the morphine, there's permissions, as it were, there's permissions, global permissions to use morphine. But morphine's funny, isn't it? You've got a drug that can reduce pain, but you've also got a drug that's very addictive, a drug that could be used on the street, that could be sold. And many nations are weighing up. Is it more important to try and ensure a greater flow so that patients who need this can get it? Or is it more important to put the locks on, to put the control in, to make sure that only very few people can prescribe? And almost most countries in sub-Saharan Africa, only doctors are allowed to prescribe. Uganda's an exception. Uganda introduced nurse prescribers for morphine, saying, we've hardly got any doctors in our country. If only doctors can prescribe, then how will it be possible for those people who are living in rural areas, how will it be possible for them to get morphine? But nurses are there. There's more nurses, so we have nurse prescribers. So you've got in the single convention on narcotic drugs, you've got this two balancing. The states that also need, on the basis of adequate statistics, they need to submit an overview of their estimated need for narcotic drugs, so that has to go into a system. They've also got to state and record every time a substance is administered to the patients. So many countries have taken these, have taken the regulations, they've taken the legislation, and they've tightened it and tightened it and tightened it and pulled it away so that fewer and fewer people are actually able to access the morphine, because even though with the legislation, it does mean every country has to set its own legislative framework for morphine availability. This was yesterday. 70,000 Senegalese suffer without palliative care. E-Hospice is an organisation that does really try and capture what's happening throughout the globe. And what I want to do is just play you a little a video just for a few minutes, which says things much more elegantly and much better than I can.
In Senegal, when people are diagnosed with cancer, the overwhelming majority is in a late phase where pain is very intense and curative options are limited. These people need pain relief, but the government only procures 1 kilogram of morphine each year, which is only enough for about 200 advanced cancer patients. Adama was 12 when she was diagnosed with leukemia, and for 2 years she was being treated in Dakar, but she passed away when she was 14.
am doom mu feebar nga tiim ko muy dem ak métit di dund ak métit bi vraiment lu métti la quoi.
non dama ko daan xool dama xool sori ma dugg si douche yi jooy sëlmuwaat génn lu ma bëgg sax mu xam ko ndax xam naa daf mi ngi métit boo xam ne bëggul sax moom ma xam ne mi ngi métit da ko daan làq sax mais xam naa lépp ci moom xam naa lépp ci moom.
Shortages of oral morphine are really common in Senegal. When a hospital has a shortage, there's no backup plan.
Là, on est en train de montrer comment on prépare le sirop de morphine. Bon, là, présentement, c'est la boîte qui nous reste. C'est la boîte qui nous reste. Mais il y a une commande qui est en cours et qui va arriver bientôt.
A week's supply of morphine is less than $1. It's extremely cheap. Money is not the reason that there's shortages. The shortages occur because the hospitals have to import the morphine themselves, and there's a lot of restrictions to that process. They have to work with 3 different government agencies at least.
It's hard for us to see the family suffer, it's hard for us to see the child suffer. We use the energy we have coming from that pain to find ways to find the morphine.
The doctors that we interviewed told us that they personally take on the challenge of finding morphine because it is so hard to have a patient who is coming to you who is in an enormous amount of pain and you have to turn them away.
When I have a patient who died from cancer and who had some morphine left, I ask the family to give them to me. All the boxes you see here were given by some patients and families so that I can give them to the other patients.
Outside of Dakar, there is no morphine, so anybody who needs morphine has to travel to Dakar to get it.
Pour ne pas te mentir, la médecine de là-bas ici c'est pas la même chose parce que là-bas on me donnait que des comprimés.
Families told us how they traveled for 10 hours or more with a sick relative to Dakar. And sometimes they arrive in Dakar only to be told that there is no morphine.
Du fait de la douleur de ma sœur, j'ai demandé naïvement si on peut pas lui mettre de la morphine. Mais ils m'ont rétorqué qu'il n'y en a plus, il y a une rupture à l'hôpital et que ça ne se vend pas en pharmacie. Donc voilà, elle souffre.
It is extremely unbearable for a person who is suffering from late stages of cancer, has had their morphine, and suddenly is cut off from their pain medication. It is unbearable for the person, it is unbearable for their family, and it is agonizing for healthcare workers who have to watch these people suffer and have nothing to give them when a medication that is so cheap could stop their suffering.
There's a third delay. And it's a delay in getting to the right place in which to be cared for. And where is the right place? Is the right place in a home, a homestead, where family are running around, where you can see your children, where you can be with others, when you can be with community? Or is the right place in a hospital where there may, or there may not, but there may be some morphine, there may be that pain relief, there may be someone. Such a hard decision because there's been so many difficulties of getting care into the community. There's also a delay because there's a lack of a support network and coordination of the pathways to care. Goodness, we talk about it here, our lack of coordination, our silo system, but in so many places that silo system, many times introduced from UK or some European countries, is really having a huge impact on people's lives, making it extremely difficult. You saw the woman, she was very fortunate, she was able to get into her brother's car. So many people don't even have that luxury. The right place when there's no food, there's no shelter, My house leaks when it rains and the bedding is not enough. I'm very cold in the evenings. And that's one of my experiences that really stuck with me when I was working in Kenya, visiting people in rural villages. And there was no sheet on the bed. It wasn't about changing the sheets because there wasn't any. There was a mattress and that was it. There was no running water. There was no soap. There was nothing because poverty was there. How do you start to offer care? But we can. There are ways. And a lot of times families are saying, who will feed my family when I'm going? The right place, I want to be with my family until the end, because what's going to happen whenever I leave? I've given you these 3 delays and you're thinking, my goodness, it sounds very heavy and very negative. What can be done? What is being done? I want to ask you to think now about some of the choice makers that we have in the world today, and actually in this room today, and also some of the change makers. I mean, in many times the choice makers, as we realise that the choice makers in our global environment, and we think about the social determinants of health, we think we make free choices about what we eat, what we do, how we go about, but often those are being controlled by the big corporates. Our decisions are often much less ours than others. But there are change makers as well. And we can be change makers. I don't know whether any of you recognise this person on the right of your screen. It's Thomas Clarkson. Don't know whether that name rings a bell either. Thomas Clarkson was one of the people who was very engaged with the abolitionist movement. All of you will have heard of William Wilberforce, but I'm very interested in Clarkson and in what he did. And he was an extraordinary man who got together. But when he was at university, he was at Cambridge, he entered into a competition set by the Vice-Chancellor. It was to write an essay, and the essay was called, Is it lawful to enslave the unconsenting? That was the essay title. He researched well, he was a very good student. He checked out the data, he triangulated, he did various interviews with people who had slaves, people who were beginning to speak against slavery, looking at the economics of slavery, and he won the essay, which was fantastic. Sometime later he left Cambridge, but travelling on horseback from Cambridge down to London, he has this extraordinary quotation in his works. A thought came into my mind, he wrote, that if the contents of that essay were true, it was time some person should see these calamities to their end. And that thought, he realised, I'm going to take my university knowledge, I'm going to take what I have, research what I know, I'm going to make a difference. And that, saying this to the students, that's what our life here in university is about. But it's not just for students. It's a call to me, it's a call to all of us. Take what we've learned and make it change the world, because we can do things about it. And against the tide, he spoke up. And many of you will know the story of this extraordinary abolition movement when the whole of British economy really depended on the effects of the slave trade and the triangle. Wilberforce, Clarkson, a whole group of men, Granville Sharp, got together and they managed in 1807 to get an act into Parliament. So what does that tell us as well? In fact, just as a comment, I hadn't registered till very recently that William Wordsworth wrote a sonnet about Clarkson's works, which you can look. So what does that tell us? It tells us there are things we can do. It tells us there are challenges, that palliative care, there is a huge need, and all of us could make a difference in getting palliative care on a global health agenda, in beginning to change how things work. Now, this slide's probably, in fact, it's not come out well, so I really apologise. There's no way that you can see that. At the very bottom picture is about patients. Then it's about family and community and the informal structure of palliative care. Then it's about the services. Then it's about this national architecture, because you need the policies in place. You need to get the training in place for health workers. So you need both the service, the local infrastructure, and that national architecture. And above that, again, there's a circle, there's a global movement. Clarkson, Wilberforce, the Clapham sect pushed forward what in the end was a global movement around abolishing slavery. And then finally, we actually, to do any of this, we need to change how we think about death and dying, a global paradigm shift. We're not asking for much here. I want to talk a little bit about some of our work. I'm conscious of our time almost. I've just got a few more comments, a few more slides, just to talk about some of the things that are happening and some of the ways that there has been change together. There's examples of extraordinary excellence, volunteers who are the backbone of the palliative care teams in a number of countries. People who are not getting paid for what they're doing, but actually making an extraordinary difference. There's an amazing program in Kerala in the south of India. Kerala has a narcotics law that they passed, which made it very difficult for any state to hold narcotics, to hold morphine. But Kerala, as a state, decided, actually, we're going to go against this. We're going to advocate, we're going to ensure that our state can. And by voices, by local people arguing, they managed to change it. And they have got a volunteer network of people. There's something about and this is capturing this picture of the Kerala work, a neighbourhood network for volunteers, meeting people, and also the some of the examples of volunteers in a number of African countries talking about what they do. Something about caring in the moment, because I've talked a lot about physical pain, but palliative care is not just about dealing with people's physical pain, though it's quite hard to deal with people's social, emotional, psychological, spiritual pain if you're not also dealing with physical pain. But vice versa, it's hard to deal with, to take pain relief away. And it's a thing that came up from our Edinburgh studies. A number of people saying, well, I don't have pain, I don't have so much pain, but I feel empty, I feel lost, my heart is breaking. I'm crying at night because I'm scared and nobody's listening to that part of the pain that I have. There's extraordinary stories and examples of people caring in the moment, providing social, emotional and spiritual care in the most extraordinary settings, supporting families to care. And I'll talk about this program that Gareth mentioned tonight, a program we're running with DFID. So much of it is about training professionals, but also enabling families to have the training they need, carers to have the training. And there's this wonderful comment from an old woman in Mawa who talked about she had enough knowledge after some support to be able to care for her husband at home. In fact, she says, I almost became a doctor, someone who wasn't able to read or to write, but actually had been given enough skill and support to look after and keep her husband, even down to the point where she was able in the end to put his body under charcoal when he died, dampen the charcoal, keep the body there cooling until the family came. People who knew what to do, support in the network that allowed people to take old traditions, new traditions and put them together, offering practical support. I mentioned this, we can come in with pain relief, but actually so much more is about also making sure the practical support is there, offering that level of service, because that's needed in such care. And being mobile. You know, our mobile clinical care is extraordinary. When I see nurses and doctors, I see community volunteers sitting down on the floor, working together. I see humanity at its very edge, the love that's shown there, the care that's shown there, for people who come together to make a difference. The clinical care in hospitals, people trained the way they need to be. And I want to just focus on this a little bit, using innovation to care. Because there's something, here we are in our 21st century world, we're so much more connected than we ever were. Mobile phones, you know, there's more people who have mobile phones in sub-Saharan Africa, the whole of the African continent in fact, than who have indoor toilets. The mobile phone technology in Africa is extraordinary. In Asia it's extraordinary. And we've got to think about innovative ways of using this to care for people. And this fantastic picture actually is some of the examples of how mobile phones are being used. They're being used by health professionals to speak to volunteers to say, this is what you can do. They're being used to patients or families to ring in, and often it doesn't involve money. It involves putting the phone on, ringing the number, letting it flash. Flashing is what most folks refer to. Flashing so that the nurse in the hospital knows this person in this village is trying to get a hold of me. There's no credit on their phone, they don't have that. But they're trying to get a hold of me, so I'm going to ring them back in order to give advice. Phones can be used for adherence, and they are with antiretrovirals hugely. They can be used for guidance. Those smartphones, in fact, are coming in many places, used to actually pick up how patients are, used to actually send data back and forward. Using innovation to care is where we're moving to. I just want to, I want to just finish now with a few words about the programme one of the programmes that we're working with here in Edinburgh with 4 partners. But the question that's asked is when we have so much happening, what is the biggest need in order to get palliative care in the global health agenda? What do we need to do? And these are needs that countries have said. We need the evidence base to know who needs the care. We need to understand the value. We need the economic value of palliative care. I talked about that at the start. We need studies to show what that is. We need the infrastructure. Now, but not all governments are supportive, but we need something that actually begins to persuade national governments. We need to be able to model good examples of care, create hope that things can change, and a continuum of care. So the programme that we have here in Edinburgh is a programme with Uganda, Kenya, Zambia and Rwanda, working with their national associations, working to build up the palliative care services actually in 3 hospitals in each of these 4 countries, creating models that are models from the hospital through to the community, because the system has to be meeting the need of the catchment area one size doesn't fit all. So we need to think, how do we make that work better? It's built on 4 pillars around advocacy, around increasing staff capacity, around ensuring timely delivery and supporting the partnerships. And one of our most innovative parts is having UK volunteers, mentors, working with their colleagues, their partners in these countries to share knowledge and to share. Now, this is a slide full of P's, so if you don't remember very much about what I say tonight, remember this, that this is some of the work about getting programmes, policies, protocols, purposeful prescribing, partnerships, pastoral care, because patients matter and the people who give the care matter. We had this amazing conference in Johannesburg very recently. You think, can ministries change? I had a time, I think, when I probably felt a little bit like what Clarkson had, though I wasn't, so I was involved in it, but I was one of many African health ministers getting together saying, actually, we are going to commit. And the African ministers made a health pledge saying, these are the things that many of us are going to do in our country. Oh, that was the case in other countries. If that was the case in places like Gaza, where there's no palliative care, almost none, and yet a huge, huge need. So many refugees who have not been cared for, but dying of cancer and other diseases. I'm going to finish. This slide talks about the future idea of sustainable development goals. You can see these 4 goals of where we're hoping to go for. I think that palliative care actually does fit into this marks of the new Sustainable Development Agenda. I've tried to sort of show where some of the thinking might be about a human right, a public health issue, something of national pride, something about who we are, how we are. I asked you that question at the beginning. It's quite a hard question. Are we ready to die? It's not a question we ask ourselves. But I hope through this talk, maybe began to think, what does it mean to, and what do we need to do to be ready to die? A number of people say to me, to be ready, it means I need to be able to talk about death and dying. So I need places and services and support. I need to be able to say goodbye to family and friends, to be able to understand what's going on and why, to be at peace with myself, and to be able to live until I die. And that can only happen when there is opportunities to live, to die as pain-free as possible, not to be screaming in pain, not to desperately wish to go to sleep and wake up dead, to be able to put in support mechanisms for families when no one is going to be caring for them after you go, when you know nobody's paying the school fees, nobody's giving the food on the table because there is no money. We need that sort of preparation and acceptance. We're all born equal, I believe, but we're born into and we die in very unequal circumstances. And we can't change this inevitability of death, but we can change the unequal circumstances, and our call is to do so. Thank you.
Liz, that was a remarkable lecture. It wasn't the most comfortable lecture I've listened to, but it was truly inspiring, and I'm sure on behalf of all people here, thank you for doing what you do. If I can just comment, I think one of the striking things that struck me from your lecture was that you're not talking about vast amounts of money. It's how such small changes can make such a big difference if there's kind of understanding in education.
Yes, I think that's such an important message, and I'm so glad you're saying it. It isn't much money. It's minimal, and yet it could make the biggest difference to the quality of life of people who are living with all of these diseases. But also, without spending that money, if we don't spend that money, rather, the cost for families is huge. And that's frightening. The cost for actually health services, for aggressive treatment, is also very huge. There is a win-win here, but I feel that, as you say, morphine costs next to nothing. There shouldn't be any reason why it's not there. Training people, implementing and putting palliative care knowledge and training into the medical and into the nursing, into the pharmacy, the social work curriculum, doesn't actually cost that much, but it equips people to have the knowledge to know what to do in circumstances they are going to meet on a daily basis.
I hope I'm just at the start of a discussion on, from the ideas you've given us. Thank you very much for a very balanced perspective, it seems. I'm a bereavement counsellor, and I'm also a member of an organisation called Friends at the End, which will perhaps contextualise. But your slide was at Professor Guthrie, with the number of conditions and complaints that older people can have, 85 plus. It reminded me of the statistic that I think, and it may be of interest to the audience, that in UK terms, in 2010, I think we had 12,000 or so people who were centenarians living to be over 100. The official statistic for 2050 is that in the UK there will be 160,000 centenarians. Now, if your challenge of palliative care, it seems to me, is multiplied X times if one then globalises the kind of broadening of that. And the other factual element that came to mind in your discussion was a research project that was launched at the tail, in fact, just about 12 months ago in America by a multimillionaire called Peter Thiel. You may have heard the name. He announced a $3.5 million research project to, quote, find a cure for aging, unquote. And the passing remark that I came across as he launched this was that in the long run, he did not see why death cannot be eradicated. And if it wasn't so serious, it would be stupid. But my question, I suppose, particularly, and again from a number of strands throughout your talk, and particularly the last couple of slides, even that one, in a UK context, as I understand it, we're about to see Margaret MacDonald relaunch her attempt to change the law to decriminalise assisted suicide. And I wonder how you would see assisted suicide, the decriminalisation, the legalisation of that, as fitting in the spectrum of application of palliative care and the way you have presented it.
Thank you, and that's a hard question. And so now I'm going to speak. I'm going to give you my personal view, and my personal view is I don't agree with this, because I strongly believe that people should have a right, but the right to care is a huge right, and palliative care does enable people to live until the time it comes for them to die. I have great difficulty in the thought of supporting someone else to take their life, because I see life as sacred. So I'm sharing my own personal view there. sharing a view also because it's worrying, and we have had a lot of discussion around this. And I respect there'll be people in the audience who do want to move forward with the euthanasia discussion and situation. But often a number of people say one of the difficulties is how are we protecting the vulnerable in all of this? How are we ensuring that those who need care are not being moved to the side, are not being, their life is not being taken from them without their wishes? Now, Margot has got a lot of systems in place to say we will prevent that, but a number of questions are still being raised. I also have to say, do question, and this is because I'm thinking almost all my palliative care work is focused around low and middle income countries, and particularly low income countries where there's so little services. And I just want to say, look, if we're going to think about spending money, small money, we need to be thinking about caring globally for those who've got nothing, because they are the ones who are absolutely most in need. But that's again it's a very personal view, and it reflects my own situation. I'm sharing that with you, but I know you probably also have different views.
Thanks, Liz, for mentioning at the end of your talk Gaza. Yeah. You and I have been in dialogue now for some time about what is happening in Gaza. I've been going backwards and forwards for 4 years now, looking at the health problems that they have. Surprisingly, for such a sophisticated country that until recent times was doing bypass surgery, palliative care doesn't figure. And I'm hoping your skills and the skills of your colleagues will ride to the rescue. And that's I view myself as a midwife trying to make a marriage between Edinburgh University and the academic institutes in Gaza. But my question is entirely different, I'm afraid, Liz. If you're involved, as I have been for most of my professional life, with the dying patient at home in primary care, it is the norm for the relative, or for me, or my nurse, to walk out of the house when the patient has died with a large black bag that contains drugs which have years to run in their original pack. It's one of the traditions of palliative care that we do prescribing, which is called anticipatory prescribing. That is, you give the patient painkillers that they might use if their regime isn't adequate. We give them extraordinarily expensive antiemetics that they might use if their regime doesn't control vomiting. But those very expensive drugs are taken, and everyone in the room should know that every medicine in the NHS in Scotland today that is not used by the designated end user, you take it back to the chemist or your family doctor, is incinerated. It seems to me that if you're interested in palliative care, it might be another marriage you might make and join many other doctors who've tried for years to persuade our government not to incinerate very, very valuable drugs that could, in my opinion, go back on the shelf. And in the most litigious society in the world, the US, Nevada and 2 other states have organized a recycling program. Now, those drugs might go to sub-Saharan Africa. I'd prefer them to go back on the shelf and the money that we save be used to supplement the kind of services that we have. So can you join me in another crusade apart from palliative care and try and stop us from destroying perfectly good drugs that our chief pharmacist and our own government for the last 12 years, that's Nicola Sturgeon, followed by Alec Neil, and even in November of last year, Hamza Youssef have said they have to be destroyed because the European legislation says so.
Yes, I totally agree with what you're saying, and actually that one of the reasons I chose that video this evening to watch, sorry, was because you saw that doctor asking those who had died, asking the patients or asking the family, could they bring in the remains of the tablets because we could use them again. I think if you've only stepped foot in a resource poor country and realised what the need is to have the waste that we have. Now I understand the legislation, but I also ask, how can we we manage so many other tricky, difficult legislations and make them work, when this does seem quite a straightforward system of legislation? There may be other people in the room who want to come in and that, who have more knowledge around the legal stage. But I do have to say, I do agree with what you're saying.
If there are no other questions coming through immediately, could I just come back on your point about assisted suicide? If anybody in the room has not seen the film documentary How to Die in Oregon, it's a very interesting illustration. Assisted suicide has been legal in Oregon for 10 years. And the documentary, which was shown in the cinemas here a year or so ago, the evidence there is quite clear. It's your particular description of palliative care, that allowing controlled and regulated assisted dying is extremely compassionate, and one could say a true application of palliative care in just the phraseology you've been using about enabling the individual to discuss and confront their death, and helping the family communicate and interrelate with the person who's dying and their own grief process. But the other important element about your concerns that you were touching on, the official statistics in Oregon, after 10 years, it is 0.23% of deaths in that state in 2012 were by assisted dying, and the rest were by other causes. So an appropriate regulatory framework, there is evidence around for us to learn from, and Oregon's not alone. So I would suggest, and the audience may want to debate about what palliative care means, but I would suggest that actually enabling it in a controlled, regular way enables true application of palliative care to those who wish to confront dying.
Well, clearly this is a kind of controversial area, but perhaps it's kind of beyond the topic.
Yes.
And it certainly deserves a forum, but I think the ethical issues there are very complex. We've got a question.
I would just like to come in on that last point, because I had experience as a clinical pharmacology research assistant into the MST morphine tablet when it was a very new product in a hospice, with having the privilege of working with Dame Cecily Saunders. And I actually take the totally contrary view to the last speaker. I agree with you, Liz, that if the people who are in this situation were given the care that we all know is possible and capable, then very few people would make the choice of assisted suicide. They would rather live fully the life that they've been given with the family around them. And I think the key thing from that is one of the points you were making earlier about educating everyone about death and dying, and particularly educating healthcare workers. And I know it was something that the hospice movement in the UK in the 70s, when I was involved, and the 80s rather, was trying to do through all of medical and nursing and other health professionals. Is that something you see happening in terms of the World Health Organization and the investment in medical training and, reaching the people who then reach the community volunteers?
Very much so, and I didn't go into. Thank you so much for what you say. There's a huge investment now around training, and it's something that our Department for International Development in its global health work has supported. And I say that's what we have quite a substantial grant given to Edinburgh, and so much of it is about enabling knowledge to be transferred across, so that clinicians, so that practitioners, so that community health workers, so that knowledge can travel right the way down. And like that woman in Maua who talked about, I almost felt as if I was a doctor, so that knowledge can travel up again and people can share together their skills. So I think there's a huge investment currently. It really, global palliative care really is beginning to push onto the global health agenda. In December, there's a large meeting in Qatar, where a number of people are presenting to a number of ministers right across the globe on the importance of palliative care as one of the key issues. And I'm really hoping that through that further changes will be made. But thank you, and it's an extraordinary experience to be speaking to somebody, sitting with somebody who was with Dame Cecily Saunders, an extraordinary woman. Thank you.
We've got just two last questions, one at the back and the last one at the front. Yeah.
Apologies if this sounds like a facetious question, but we have sex education in schools. Would it be possibly a sensible thing to introduce some form of death education?
I don't think it's facetious. I think it's a great idea, and it's an idea that the health promoting palliative care has been really saying. Children need to be able to talk about this, because to be honest, in almost every family, people will know someone who has died, and therefore children often they're not given the opportunity. So to have those conversations, to have that permission to speak, to have the knowledge, would be tremendous. Yes.
Yeah. One of your slides said that palliative care neither hastens nor promotes death. So that, this seems to me to be very important in relation to assisted suicide. I wouldn't want to take an opinion on that because I'm a friend of Margaret MacDonald, but I'm a retired doctor now and have worked in international health in many parts of the world. And I've certainly met many of the problems you've been discussing. In particular in Malawi, I used to have quarrels with medical stores as to whether hospitals without doctors could have morphine, which I felt to be absolutely essential. But just one point to make as a comment rather than a question. On 2 occasions in my life, I've prescribed morphine for myself, and it certainly enabled problems to be solved. I never felt later that I wanted to do it again when I didn't need it, but I think that in many cases doctors should experience the things that that other people are going to need. And
it's a very interesting thing. And health ministers, and one of the biggest changes in Kenya, the health minister there was talking about how they had experienced a partner living with a cancer, and how that had changed how they felt about palliative care, and really made a phenomenal difference in integrating palliative care into the systems. Thank you.
So have I got that right? You're proposing that we give the Scottish Government morphine, is that right? Right. Okay, on that note, perhaps that's a right note. Thank you very much for a really, really inspiring lecture.
Thank you.
This production is brought to you by the University of Edinburgh.